Okay, so thank you for having me. I'm going to talk a bit about the Inspect SR project. So this is some work that I've done. We've done in collaboration with Cochrane. It's developing this tool for assessing trustworthiness of RCTs. Just before I begin, so I want to make it very clear that I'm not accusing anyone of fraud or any other kind of misconduct here today. Okay, so we might say that a study is problematic or untrustworthy, but we leave open possibility that okay, this could be due to fraud or research misconduct, or it could just be due to very critical errors, serious errors in the conduct of the study. In terms of my declarations of interests, so I do stats editing for various journals, and I also undertake misconduct investigations for various journals and publishers, and sometimes I am paid for that. Okay, so let's motivate this work a little bit. Let's use the example of ivermectin for COVID-19. All right. So a couple of systematic reviews of ivermectin suggested that ivermectin had a very impressive benefit in COVID-19. All right. So I've got the pooled sort of risk ratios over on the right there, and they both suggest an impressive reduction in mortality if you take ivermectin with COVID-19. Okay. So that sounds good. All right. That's good news. Unsurprisingly, that received a lot of attention. Okay. So it received a lot of attention in the media and on social media. And I've shown you some of that on the slide here. A peer-reviewed study shows that ivermectin prevents and treats COVID-19. The strength of evidence for ivermectin has been supercharged. All right. And it was actually used by a lot of anti-vaxxer groups who were able to say, look, you don't need a vaccination. If you get COVID-19, you can take ivermectin. It will save your life. All right. So that all sounds good. However, it turns out that there was a problem with some of the RCTs included in these systematic reviews. So what I'm showing you here is purportedly data from one of the ivermectin RCTs. Okay, so this is a standard format RCT data set. We've got like one row per study participant, one column per variable, per piece of information in the study that was collected. Don't worry about the individual values. What I'm going to do now is I have zoomed in on that data set. So here's a snapshot from the data to make it a bit easier for you to see. And I'm just going to give you a minute or so to have a look at this and see if you can see anything that looks unusual about this data set, perhaps. Is there anything that looks odd about this? I think Matilda's got it in the chat. Matilda writes, data is repeated. Okay. That's what I was thinking of as well. All right. Let's add some color coding to this, right? If I add some color coding to this, you can see that there are repeated sequences here, right? Entire blocks are repeated. So I can see lots of people getting that in the chat. So that doesn't look good. And actually, if I return to the original data set and add some color coding here, you can see there's lots of repetition. All right. So this is only the first or a section of the data set. If I showed you the whole thing, this continues throughout. So there's lots of repetition in this data set, okay? So clearly, this is not authentic RCT data, okay? And one possible explanation is that this is a crude attempt at data fabrication, where somebody has copied and pasted blocks of data into a spreadsheet to give the impression of having this full RCT data set. So that's not good, okay? Now, actually, it turns out that there were similar problems with some of the other ivermectin RCTs. And actually, once we remove these problematic studies from the ivermectin systematic reviews, this impressive benefit of ivermectin disappears, okay? We're left basically with uncertainty about whether ivermectin helps, harms, or does nothing at all, all right? So this was being driven by these problematic studies. Now, you might think that's a surprising example, okay? But we don't think it is a surprising example. And in fact, we think it's inevitable that this will happen. Because let's think about what happens when we do our systematic reviews. So first of all, we attempt to identify all of the trials that have been done on the review topic. And that means that, you know, if there are any of these problematic trials, they're going to be sucked up, okay, and included in the review. And then what do we do? Well, we typically appraise the studies using something like a risk of bias tool, all right? But those tools are predicated on the assumption that the trials are authentic, okay? The authenticity of the studies is not usually assessed. And that's a problem because it turns out that many, not all, but many fake trials, problematic trials, report pretty good methods, actually, all right? So they're not picked up by risk of bias tools, all right? Risk of bias tools aren't designed to do this, okay? So they get included in meta-analyses. And then I don't need to tell people on this call that systematic reviews are, of course, very influential. They're included in guidelines and they have an influence on patient care. So you can kind of start to see how systematic reviews might act as a pipeline for fake data to influence patient care. Okay. And sure enough, we see examples of this in lots of clinical areas. Okay, we have lots and lots of examples of this now. I've just put a few examples on the screen here of systematic reviews in different clinical areas. Vitamin K for the prevention of fractures, tranexamic acid for postpartum hemorrhage, psychological therapies for the management of chronic pain. So these are all examples of systematic reviews where there have been serious doubts about the authenticity of some of the eligible studies. Okay. Now, Cochrane noticed that this was a problem. So a few years back, they introduced the policy for managing potentially problematic studies. All right. And that policy says do not include problematic studies in a systematic review, which I think we can probably all agree is a good policy. All right. We don't want to include problematic studies in a systematic review. However, it prompts an obvious question. How are we supposed to identify these problematic studies in the first place if we're going to exclude them? Okay. Well, can we just look at the retraction status of the paper, right? Can we just use that to determine whether or not a trial is problematic? Well, unfortunately, the answer to that question is no. We can't rely on retraction status because it typically takes a very long time for problematic studies to be retracted. And in fact, many are never retracted at all. So I've got an example on the left here. This is the outcome 5 years after reporting 172 problematic clinical trials from one research group. So you've got the publishers listed on the x-axis there. And if you have a look, you can see that there is considerable variation between the publishers, but overall, the majority of these trials have not been retracted after 5 years. And I think these are fairly clear-cut cases, okay? So this shows that we cannot rely on retraction status alone to be our indicator of trustworthiness, okay? We cannot rely on retraction status of the study alone to say whether or not a study is problematic. So what do we need? Okay. Well, do we need some sort of tool to identify fraud and misconduct? Okay. Some people approach this problem by saying we need some sort of diagnostic test for fraud. Okay. And our view is that it is neither necessary nor desirable. And in fact, I might add possible, okay, to develop a diagnostic test for fraud. All right. First of all, there are the obvious legal consequences and harms to accused researchers with this. But perhaps even more importantly, we just don't think it's relevant, okay? All that matters is the trustworthiness of a study. So what do I mean by that? What do I mean when I say all that matters is the trustworthiness of the study? Well, let me quickly show you an example, okay? This is a baseline table from a published RCT. Doesn't matter what the intervention is, 2 groups, and there's your patient characteristics at baseline, okay? Well, I'm just going to tell you now that all these values I've highlighted in red are not possible given the data in that table, okay? They are completely inconsistent. They could not possibly be right. And actually, the same is true throughout this paper, right? With the results, with the primary outcome, the results could not possibly be correct. Now, once you see inconsistencies to such a great extent, it doesn't matter if that is due to fraud, misconduct, or just due to very serious error, right? All that matters is we can say that the data are untrustworthy. we should not use this data to influence patient care. All right. So that's what I mean when I say what matters is the trustworthiness of a study rather than the accusations of research misconduct. All right. So we think that a trustworthiness tool should help the user make a judgment about a trial's trustworthiness and then to transparently articulate a basis for that judgment. Okay. And we've written a bit more about this in the linked article. So, with that in mind, we set about, in partnership with Cochrane, to develop Inspect SR. All right. So, Inspect SR is a tool similar to a risk of bias tool. Okay. But this tool is for identifying problematic RCTs in systematic reviews. All right. How did we develop it? Well, we started by assembling a long list of checks that could potentially be performed to assess trustworthiness. Okay. We took that from some previous research, and we conducted a new survey of experts as well. And we started with a long list of 76 potential checks. We then applied those checks to lots of trials and lots of Cochrane reviews to learn a bit more about their feasibility, about the impact of applying them, but also about how they might malfunction, right? How they might go wrong or be misinterpreted. Simultaneously, we entered the checks in that list into a large international Delphi survey, okay, to see which checks were considered useful and feasible by the expert community. And then both of those strands of evidence fed into a series of consensus meetings. And we used that to decide which checks should be included and how should they be arranged and operationalized. And that gave us a draft version of the tool with 21 checks. And then we did lots of testing of the draft version of the tool and got feedback from lots of users. And we use this to deliver the final version and to write an associated guidance document. Okay, so that's how we developed it. So what does it look like? Okay, so at quite a high level, it looks like this. This is the structure of the tool. So Inspect SR guides the user through a series of checks arranged in 4 different domains. Okay, so a similar structure to anyone familiar with risk of bias 2, for example. Okay, and it prompts the user to make a judgment about study trustworthiness in relation to each one of those domains. And then these domain level judgments feed into an overall study level judgment. Okay. And one point of differentiation with something like a risk of bias tool, we say, if at any point during this assessment, you say, I've seen enough here, right? I've seen enough to have serious concerns. And that could happen at any point during the assessment. Okay. Well, if you really have seen enough to have serious concerns, we say, well, you don't need to proceed with the remainder of the assessment if you've really seen enough, in which case the overall study level judgment should be one of serious concerns. Okay. Okay, so that's just like a brief summary of how the tool was developed and the overall structure. Okay, but what's in the tool? Okay. Well, let's think about this with an example. So this is a Cochrane review, probiotic treatment for women with gestational diabetes to improve maternal and infant health and well-being. Okay, and I want us to look at one trial in particular that I've marked in this forest plot by Badanush and colleagues. Look at that forest plot. You can see it doesn't look unusual in terms of its results, but importantly, nor does it look unusual in terms of its risk of bias assessments, right? So over on the right, we can see it looks pretty good, greens and yellows, and it's very much in line with the other trials in the review, okay? But what we're going to do now is we're going to apply just a few of the checks from Inspect SR to this trial to see what we find, okay? And I'd really emphasize that I'm just showing you a few of the checks in the tool just to give you a sense of the variety of things that we look at as part of a trustworthiness assessment. I also really want to emphasize, by the way, that the authors of this review have done nothing wrong, okay? There has been no expectation that we routinely check studies for trustworthiness. So I'd like to emphasize that point as well. Okay, so let's proceed with our Inspect SR assessment of this trial. So our first domain, inspecting post-publication notices. And our first check is, does the study have an associated retraction, right? So that's a simple one. If the trial has been retracted, That's it. We're done. We don't even need to proceed any further. And actually, it turns out that this trial has now been retracted. Okay. So I'm taking this from the journal website, the text here. It says they've done some sort of review. They were unable to confirm the integrity of the trial design. The outcome was that the conclusions are unreliable. So they've made the decision to retract. Okay. So if we see something like this, it's very easy. We obviously do not want to include the retracted trial in our systematic review. Okay. And we wouldn't even need to proceed with the remainder of the assessment if we saw something like this. However, importantly, the trial had not been retracted when the authors did their Cochrane review. So a reasonable question to ask is, had we performed the Inspect SR assessment, would there have been any other signs that could have alerted us to potential risk here? All right, so let's proceed with the Inspect SR assessment and see what we find. So another check in the first domain, does consideration of other studies from members of the research team highlight causes for concern? So here we ask people to search on the Retraction Watch database, okay? And here, if I search for the senior author, I find a huge number of notices, okay? So 72 notices. These are a mixture of retraction notices and expressions of concern. And we obviously have to go and look at these, okay, to see what these expressions of concern are about. And if we do this, we see that they are, repeatedly concerns about data integrity, research integrity. Okay. So if we saw that the research team has this big track record, I suppose, poor track record with research integrity, that might give us some pause. All right. Okay, so the next domain, inspecting conduct, governance, and transparency. One check I'll show you here. Are there important inconsistencies between the publication and the registration documents? So this trial was retrospectively registered. I mean, registered after the study was completed, okay? But nonetheless, there are various substantial inconsistencies between the paper and the registration page. So, for example, the recruitment period completely differs in the paper compared to the registration. The description of the control arm completely differs between the paper and the registration. And that was actually later changed on the registration page to match the paper. And what I'm showing you at the bottom here is clinicaltrials.gov record being amended retrospectively to make the control arm match what was written in the paper. Okay. So that doesn't look too good. Okay, so let's jump to the next domain. I'm inspecting text and figures. One check we have here, is there evidence of manipulation or duplication of figures? Actually, there weren't any figures in this particular paper. So I'm going to show you a figure from a completely different trial, published trial, okay? So this is a 2-arm RCT comparing active laser to placebo, okay? And these are just results from this study. Have a look at this for, I don't know, 20 seconds, 30 seconds, and see if anything strikes you as potentially unusual about this figure. So I think people have started to notice that this is the same figure 6 times, right? So even though these are supposedly 6 different measures measured in different units, somehow they all produce the exact same data. Okay, even the axes are numerically the same. All right, so there's no way that can be authentic. All right, if we see something like this, something is clearly wrong. Okay, so the next domain, inspecting results in the study. Now, this is the domain which has some checks of data, some statistical checks. Okay, and I think people see this and automatically think that's going to be hard, that's going to be difficult. But we've deliberately created Inspect SR so that it can be done without any advanced statistical knowledge, okay? There are a couple of basic numerical checks in here, which are novel to people, right? They won't be familiar with them, but they're not hard, okay? And indeed, we're making software available to people that can be used to run these checks. So let me just give you one example of a check in this domain. Are the means and variances of integer data impossible? What does that mean? Okay, well, I'd like you to look at the APGAR scores in the top 2 rows of this table. Okay, now the APGAR score is a variable which only takes integer values, whole numbers, 1, 2, 3, 4, etc. And it turns out that the highlighted values cannot occur for the group sizes in this study, okay? There are only a limited number of possible means and standard deviations you can get for an integer variable with a given sample size. And these values here are not consistent, all right? So we check this using methods called grim and grimmer, all right? Another check in this domain. Are any outcome data, including estimated treatment effects, implausible? So now I'm going to tell you that the second trial in these forest plots here is another trial from the same research team, okay? And if you look, you can see that the point estimates are almost identical for the estimated effect on hypertensive disorders. That's almost the same between the two trials. And also for cesarean deliveries, that's almost the same between the two trials as well, okay? And I've shown it for these two outcomes here, but actually the same is true for several of the other outcomes in this review. They have identical point estimates. Now, even though these are similar trials, similar intervention, similar population, it's really unlikely that you're going to get the same point estimate across all these different measures in these small trials due to random variation, okay? So that doesn't look too good either. So I won't read all this. This is just a summary of what we just did, okay? And what we're saying here is, if we did apply Inspect SR to this trial, we would identify concerns in several domains. We would have serious concerns about the study's trustworthiness, and we could then exclude that study and prevent it from having an influence on patient care, okay? So Inspect SR is now available, and it's now been endorsed by Cochrane for use, which is good. We've made an editable template available, but we've also made a detailed guidance document with examples of each check. Now, this is like a living guidance document, I suppose. We are going to continually update it as new software becomes available. And there's a new update planned in the next month or so, which will add a load of software that people can use to do this. Okay. That's all on Open Science Framework. Okay. Just easy to access. Now, I'll also mention that we have some free online training workshops, okay, to take you through an example. Okay, so you'll get a chance to apply Inspect SR to a published trial, try out all of the checks, and we'll talk about them all together as we go. Okay, so these are 2-hour free online training workshops. We've got a couple of dates coming up. We're doing about one a month. I'll just put those links in the chat. The times are in London time, UK time, although the first one of these has kind of been timed to be convenient for North America. I guess there was some demand for a time in North America. If you try to book on these and they're fully booked, just email me and I'm sure I can get you on the course. Okay. All right. So here's just an example of how problematic studies can impact clinical guidelines. Okay. So this trial was retracted. This was a trial for elevation of the head with a fetal pillow during cesarean delivery. Okay, so this trial got retracted, and then NICE subsequently reversed their recommendation of that device, and the Royal College of Obs and Gynae retracted the scientific impact paper. Okay, now the key point I want to make is that if we had assessed the study using Inspect SR, we would have flagged problems ahead of retraction, okay? In fact, even in the abstract, there are numerical anomalies in the key results from the study, okay? So the results that I've highlighted in red here are inconsistent, okay? If we'd just done the check, we could have avoided including this in an influential clinical guideline, all right? Okay, so let's think about this issue then, because we have new threats, new challenges, new considerations with regard to problematic research, all right? So what I'm showing you here is, again, purportedly an RCT data set, okay? Please don't be alarmed that I'm showing you people's names and dates of birth, because these people do not exist. So they do not mind, okay? Have a look at this, maybe a bit trickier than the others, I'm not sure. Have a look at this for, again, 10, 20 seconds or so. And I want you to tell me if anything strikes you as unusual with this data set. Let's give you 20 seconds or so to have a look and a think. Yeah, I think people are starting to get it. Okay. So there appears to just be no correspondence at all between name and sex in this data set. Okay. So actually, this data set has been generated by ChatGPT. Okay. ChatGPT has generated this data set when prompted to do so. And as people have noted in the chat, there's just no correspondence between name and sex at all. All right. So gender is a complex issue, but here there's no correspondence whatsoever. Alison, Jessica, Whitney, Jennifer, Bianca are all male. If we have a look, I think I can see Robert, Caleb, Sean, for example, are all female. No correspondence whatsoever. Now, I've only shown you the top of this data set, but if we look at the full thing, well, people in this data set have multiple eyes, which is fine. People often do have more than one eye, but actually in this data set, we have people with two right eyes, we have people with different birthdays for each eye, and one person has as many as 5 eyes, which is too many eyes, okay? So there are clear problems with this, and actually those problems are pretty easy to spot if we can see the underlying data, okay? Of course, the problem is that we often don't see the underlying data, right? Or journals don't request the underlying data for review. So problems like this may, to some extent, remain hidden, right? The question is, how easily can we pick them up in the associated published paper, as we are attempting to do with Inspect SR? But we need to be mindful of this, okay? Because I think there's a real risk that LLMs are going to be used both by loan fabricators, but also by paper mills. Paper mills are companies who basically charge for authorship on fake or junk papers, okay? There's a real risk that all these kinds of fabricators are going to start using LLMs and potentially produce more ambitious, possibly even more convincing forgeries, okay? So this is something we need to keep an eye on. Now, if we do have the IPD, the individual participant data, that prompts the question of how should we check this to identify these kinds of problems, okay? If we can access the IPD in whatever context, how should we check it? All right. Now, there's a couple of attempts to answer this. So first of all, Kylie Hunter and colleagues have proposed the IPD integrity tool, okay? But we're also developing Inspect IPD, so an extension to Inspect SR that can be used when you have access to the individual participant data. And I've just got a few basic examples showing how access to the data can be useful for detecting problems, all right? So in the first one, just plotting a baseline variable quite clearly shows there's repetition in the data. The second one is a baseline measurement from an RCT. The two study groups are divided by the red vertical line, okay? And you can see this very strange sort of bulge in the data in one of the arms. That would not be compatible with genuine random allocation, okay? If there was something odd going on, we'd see it in both arms, basically, okay? So sometimes very simple data visualizations of the IPD can be useful for spotting major issues. Okay. Now, I've just said that AI might be a threat, might be a risk, but maybe it can also be helpful, okay? So there's some work going on around the question of how we might use AI to assist with trustworthiness assessment, right? So there's a project going on called Inspect AI that's being led by Alison Avenell and colleagues at the University of Aberdeen and Colby Vorland, Indiana. All right. And the way this works is this is a prototype. It's still in development. But the way this works is you drag your PDF into the software and it will help you to perform some checks. All right. It's not performing the checks for you. It's not making the trustworthiness judgments for you. That would be a problem, I think, right? What it's doing is it's helping to retrieve the relevant information or direct you to the relevant information that you need to make that judgment yourself. Okay. So here it's doing things like checking for retraction and expression of concern notices. And here it's sort of checking the retraction watch database of the author team to look for a history of problems. Okay. So this kind of stuff's in development, and this could potentially really help to speed things up. Okay, so what does the future hold? There's still lots of work to do with Inspect SR. So when we did user testing of this, first-time users reported a median time of 45 minutes per RCT. I don't think that's too bad, given that it was first-time users with very limited guidance. An experienced team has just applied this to a collection of 35 trials. They've reported a median of 35 minutes per RCT. I believe they're hoping to present some of this at the colloquium. Again, it doesn't sound too bad, but as I say, nonetheless, it is still relevant and important to ask whether or not this could be reduced with the application of AI. There's other work to do though. So Inspect SR has been designed for RCTs, okay, primarily in the systematic review context, or any sort of post-publication review context works as well. However, we are aware that adaptations are needed for different contexts, okay? So we are developing Inspect JR. This is a version of the tool to be used in journals for editorial assessment, okay? We are aware that different versions of the tool are going to be needed for different study designs. So for example, for non-randomized studies, so we're developing Inspect NRS. And as I've already mentioned, we're developing an extension for when you can access the IPD, okay?
Thanks for that, Jack. Really great and interesting talk. Do we have any questions in the chat? Great. Starting to come in. So we got one from Maria. They ask, what is the intra and inter-rated reproducibility of Inspect SR?
Yeah, it's a good question. And I guess we'll find out a bit more about this as we've got more real world use, I suppose, and we can test this a bit more. One point I would emphasize, though, is that the ideal way to apply Inspect SR is, as with everything else, in duplicate. Okay. So we have two people applying it separately and reaching an overall agreement about what the assessment should be. Okay. So I think probably the most appropriate thing to do is to think of the inter-pair reliability, okay? The inter-pair reliability. The two pairs come to the same conclusion. The other thing I'd emphasize is that, so I've kind of used it in a review recently. It is really helpful, I think, if you do have a pair of people with slightly different backgrounds or areas of expertise. It really worked very well for us recently, where I was doing it as one of two assessors. I was the methodologist, but my colleague was a clinician, okay? And that worked really well because the clinician was able to spot lots of things that would not have been obvious to me, right? Like a clinician is able to say, I know that there's no way that this would be plausible, which wouldn't be obvious to me as a methodologist. So I think domain knowledge is really important. And actually, I think that it's probably you're in a better position if you're a clinician and we can teach you some of the basic statistical checks you need to do this. I think that's going to be much easier than taking a statistician like me. You're not going to teach me all of the clinical sort of stuff I need to know to make some of those assessments about clinical plausibility. Hopefully that answers that one.
Thanks. That's really helpful. And it does highlight the importance of having a diverse systematic review team.
Yeah, I
as
agree.
well. Got a question about the workshops. Does one need to be prepared by bringing the case, for instance?
No. We'll work through an example, a worked example that's supplied by us. Yeah. If you click on those links, it's got a bit of information there. Yeah.
I'm glad there's so many questions coming in chat because I thought I had a great question about the threat of AI, and then you already preempted it with the slide. So I was like, I scrap that now. But okay, so someone asked, okay, that's already answered. How would you report the findings from Inspect SR?
Yeah, I'd refer you to the guidance document where we just describe this, okay? And we have like a clear template for you to use. The idea is that you're going to report this transparently. So just like you would for a risk of bias assessment, where you report your assessments in each domain and the reasons for those, the idea is you're going to do the same with Inspect SR, okay? That needs to be done for all of the studies that are assessed in the review, okay? So this includes the ones that you exclude for trustworthiness concerns. We need a transparent account of why you've done that, okay? So a bit more information on that in the guidance document. And as I mentioned before, there's that editable template for you to fill out as well.
We got a similar question from Matteo, but he's particularly interested in if there's any specific examples out there of published systematic reviews that have used SPER-SR. So he says he can only find one, which is evaluating the use of VR for weight management.
It's brand new, so I'm only aware of two. I actually wasn't aware of that one, so that's a third.
That's good.
There are a couple out there. If you want to email me, I can try and send those examples to you. I'm not necessarily saying that those are exemplars. I'm not saying they're not either, right? I've not actually checked how they've reported it or if they've done it to a good standard. But if you'd like to email me, I can try to find those recent examples for you.
Got a question about don't know if this specifically references the IPD, but do we always need access to the raw data of the trial when applying SPER-SR?
No, never. So just to clarify there, okay, Inspect SR does not require any underlying data, okay? It is purely based on the manuscript or the associated documents like the registration page. You might look at any sort of associated conference presentations or anything like that. Inspect SR does not require the raw data. What we are saying is, if you do have access to the raw data, that's really useful, right? It really improves your ability to detect things. But the question is how? What should you look at in the raw data? So we are developing an extension, Inspect IPD, that can be used when you have access to the data, okay? So hopefully that clarifies that one.
And then when can we get this routinely into peer review to stop these bad studies being published?
It's a good question, right? It's quite a common question, that one. So why did we target this at the systematic review stage and not earlier on in the pipeline, right? The reason for that, there's a couple of reasons, right? So first of all, if we targeted this at the editorial assessment stage, well, a lot of journals just wouldn't use it, right? A lot of journals, let's be honest, don't really maintain high standards of scientific integrity. They will publish these trials anyway, okay? So that means that those trials will be published anyway, and then they'd be sucked up and included in the systematic review, and we wouldn't have solved the problem, right? Problem, as I said, is in a systematic review, we bring in trials from everywhere, right? We try to be comprehensive. So that's one reason why it makes sense to say, hey, at the bottleneck of systematic review, let's do these checks now to make sure that we're not including them in the systematic review. The other reason why it makes sense to do this at a systematic review, a bit like the example I showed you, where we could compare results across trials, sometimes by comparing a trial to other trials that have been done on the same topic, it makes it easier to identify some of these features. Okay, so that's the other reason. That said, it does make sense and it would be useful to have checks at the editorial assessment process as well. Okay, why does it need to be one or the other? Let's do both. Some of the checks that we have in Inspect SR don't make sense in that context. So we are developing Inspect JR to be used in journals at the editorial assessment stage. Yeah.
As I suppose we're never going to stop problematic studies being
Probably
published.
not.
That's just the sad reality of things, and with the incentives to publish for scientists is yeah, it's sadly just never going to happen.
Massively, massively.
Mm.
But as responsible systematic reviewers, Cochrane reviewers, whatever it is, we can do the checks. We are the people who can sort of act as sort of like the safeguard to stop this stuff from being included in a pooled estimate and then being put into a guideline or whatever. So I think we're almost like the last line of defense, I suppose, right? To stop this stuff from getting to people.
We got a question from David about so does your program check statistical analyses? If so, what designs can it cope with? Can it do Bayesian analysis?
So that's a big question, right? So we ask people to assess various aspects of the data and the results, okay? But we're not asking really people to do any advanced statistical analysis themselves, okay? We're prompting people to, for example, check, are the p-values, say, that are reported in this paper compatible with the summary statistics that they've reported, acknowledging that they are rounded, etc. Right? So we're asking people to do some basic consistency checks, such as this, all right? Because quite often, if somebody has fabricated a paper, they will forget that they need to make all this stuff coherent, consistent, I guess. And that introduces these anomalies and inconsistencies. And by asking people to perform some basic checks, they can identify these kinds of issues. Okay, so we're not asking people to do any complex analyses themselves. I'd also just say that it's not a program. Okay, so Inspect SR is like a risk of bias tool. It's like a protocol, a list of checks. Okay, so we are prompting the user to perform a guided trustworthiness assessment with a series of checks to help them make a judgment. So it's not a piece of software. The software I mentioned, Inspect AI, that is being developed to assist reviewers in doing this more efficiently. Okay, but Inspect SR is very much like a risk of bias tool. So I hope that clarifies.
All right, this still quite a few questions to get through, but we've got I think about 14 minutes. We got a question about specifically the tool itself. Is there a cutoff for the number of some concerns that would lead the reviews to reach conclusion that the study overall study judgment has having a serious concern?
The short answer to that is no. Okay, no. There isn't just like a strict deterministic algorithm that says if you tick this number of boxes, you should have serious concerns. That wouldn't be appropriate, right? I think tools that use this kind of score or algorithm type system have serious problems. The idea here is it's to help you make an assessment of the paper. You still need to use your judgment, your knowledge, and your understanding, though, right? It's still a human judgment about whether or not you should have concerns. What we do say is, okay, so if you do have serious concerns in any domain, okay, then that will basically always be enough to warrant serious concerns overall, okay? But we don't say, if 3 checks are failed, it's automatically serious concerns or something like this. Some checks, right, if you fail them, they might reveal a problem so serious that one check being failed is enough to warrant serious concerns. In other cases, a check may be technically failed, but it's not really enough to give you concerns at all, right? Because you say, well, that just looks like a typo or something like that. We wouldn't want to exclude a trial on that basis, okay? I suppose one thing that's worth mentioning as well that I didn't mention during the talk is that as with everything else, risk of bias and other sort of aspects of a systematic review, it's important to have the correspondence with the authors to try to resolve some of these anomalies, queries, concerns as well, okay?
Yeah, and I think it's helpful to know as well, like with risk of bias tool, that there's just going to be some studies that don't provide the information that you need, and yeah, it would be harsh to penalize them. Um, so can Inspect SR be integrated into a living or rapid systematic review?
That's a good question. I mean, I don't see why not, okay? But again, this is all speculative at the moment, okay? I think as with other aspects of rapid reviews, the question is, how can we do this as efficiently as possible, right? And responsible AI tools may be part of the answer there, okay? But they need to involve this human element, okay? So that's a speculative answer, but I don't see why not, is what I would say.
Okay, then we've got several questions from Mike Clark.
Okay.
So they're a co-author on the Inspect SR.
Mike is, yeah.
Yeah. So first question is, how big is the problem of the influence of including problematic trials in systematic reviews and meta-analyses compared to the problem that an average of 40 to 50% of trials based on the Cochrane methodology review are never published and therefore not included in systematic reviews that rely on published data alone?
I don't fully understand the implication of the question, Mike. Like you've mentioned another thing, there's a serious problem. I would say problematic studies is also a problem. And the fact that this other problem exists doesn't make problem one go away. but maybe I'm missing something there. So, but it's a reasonable question to ask how many reviews are influenced by problematic studies. Okay, that's obviously a difficult thing to assess or to quantify because those studies have been in disguise up until now. All right. As we sort of see people start to use Inspect SR at scale, we'll start to get sort of a better idea of how many reviews are affected. We do know that lots of reviews include retracted trials. Okay. Retracted studies are the tip of the iceberg. All right. There's some work in the BMJ, the Vitality study, for example. They looked at just retracted studies in systematic reviews and found what 800, 900 examples just from their search. And again, that's the tip of the iceberg. So it's a big enough problem for Cochrane to say we need to do something about this. And indeed, we have done something to try to address it.
Okay. Second question is, how well have the trials of co-authors of Inspect SR performed when assessed using the tool?
I invite you to assess them, Mike. It'd be interesting to see, right? And if you identify any problems, I'd be keen to try to follow those up and correct them.
Do the problems cast doubts on the value of systematic reviews and meta-analyses, and does much more need to be done to ensure that large, definitive, high-quality trials are done in order to provide reliable answers?
Yep. So does it cast doubt on systematic review and meta-analysis? Well, not if we do them properly and carefully, right? So what we're saying is, up until now, we haven't routinely considered the trustworthiness, authenticity, whatever you want to call it, of these trials, okay? That, I think, has been a major omission, right? Cochrane have recognized that that's a problem and have introduced this solution to tackle that problem, all right? We have the solution now. So systematic reviews are very valuable if we do them well. Now, there's this other problem that you mentioned, Mike, that sometimes the high quality trials don't exist in the first place. And again, that's another very important issue. All right. But again, I think two things can be true, right? We could have this problem that quite often in many fields, high quality trials aren't being done. This doesn't alleviate or sort of preclude this problem that problematic trials are being sucked into systematic reviews, I think. So again, I don't fully appreciate the implication of the question, if you like.
I think the fourth one is more of a question to Cochrane rather than you, Jack. Is you began with the ivermectin example, and it might be interesting for Cochrane to say something about the reliability of the current Cochrane review, which was published in June 2022, in relation to, for example, how many trustworthy trials have become available since then, given the larger amount of studies awaiting classification ongoing.
So I think that was a question for Cochrane, I think, and I am not Cochrane, so I won't make any statement on that.
I am also not solely Cochrane, even though I work for Cochrane. But yeah, maybe that's something we can take offline by email. And then one final question from Mike. In regards to retraction, sometimes an article is retracted because of problems with the article, not with the study. So is it important to check the reason for retraction rather than automatically excluding the trial?
No, so we've made this tool to be consistent with Cochrane policy here, okay? And Cochrane policy is quite clear, right? Do not include retracted articles as the basis for data in a systematic review. Now, if if an article has been retracted due to problems with the article and then replaced, okay, with a corrected version of the article, then that's a different issue, right? We can assess the replacement version and we can use that in the review. Okay. But Cochrane policy on this, I think, is pretty clear, right? If we just have this one article that's been retracted, that doesn't get included in your meta-analysis, for example. Yeah.
And then we've got one final question here. And then there's also some interest from other people to get in touch with you, Jack, regarding helping out with their own reviews and using Inspect SR. So I'll leave it to you to.
That's okay. What I'd say is if people do want to contact me with any queries, they can do. I'd also recommend attending the training workshops where we go through all this in a lot more detail. We are obviously, as you'd imagine, receiving a lot of requests for help with this. So I will do my best. But at the moment, I'm saying I'm unable to commit to, for example, joining the team as a as a member or a co-author or whatever, but I'll try to answer queries to the best of my ability. Yeah.
Okay. One final question then. Did you compare the classification? Oh yeah. Did you compare the classification of the same trial using different trustworthiness tools? So in other words, how does Inspect SR compare to other existing trustworthiness tools?
Yeah, I mean, I know that something's been submitted to the colloquium looking at this, like comparing Cochrane pregnancy and childbirth tool to Inspect SR assessments. And the major point of differentiation seems to be that Inspect SR does include some of these guided checks of data and results, for example. So it does appear to detect a few more studies than you would do otherwise, I guess. But again, there's some work I anticipate being presented at the colloquium about this.